Very good morning. Welcome all of you to the ISG Masterclass Next series. This is series 4, which will focus on challenges in day-to-day practice in gastroenterology. We know that ISG is always, Indian Society of Gastroenterology is always in the forefront of disseminating science. And we started the masterclass during the COVID period, and it was found to be quite useful and quite popular. So we decided to continue this program even after the COVID time. And I thank all the governing council members, including the president, past and present, past president as well as the president-elect, for supporting to create this program. Especially, I would like to thank Sudipta Dar Chowdhury and Dr. Bhaskar Nandi for the efforts they have taken to create this program. We have selected eminent speakers and very talented and experienced chairpersons and moderators. Let me tell the attendees that you can post your questions in the link provided, and there will also be some poll questions. So please listen carefully and try to answer all of them. Can I ask Professor Sandeep Nijavan, our president, to take over now?
Yeah, good morning, everyone. I bring greetings from the Governing Council of Indian Society of Gastroenterology, and it gives me immense pleasure that we are restarting our master classes, which had been a great success during the COVID times, where at that time the physical interactions were almost nil, and it was a grand success that time, and there was a gap of around 1 year. Then we thought of restarting our virtual classes again, because all need to travel for the physical classes, which is difficult, and the residents for the residents actually, they may not travel and they may attend these classes. It's not only for residents but also for practicing gastroenterologists. It's a great it can be actually seen wherever they are actually practicing. And for the first class, we have chosen none other than Dr. Sarin, who is the opening batsman. If he opens the inning, then it will be a great success. He is the director and chancellor of ILBS Hospital, Delhi, and he requires no introduction. He has done so much of great work in hepatology. Globally, he is known for a lot of his work. So he'll be the speaker, and we'll have two eminent chairpersons with us, Dr. Ajay Duseja, who is the head department of hepatology at PGI Chandigarh, and we have Akash Shukla, who is actually heading he is the director of hepatology unit at Reliance Foundation Hospital and Research Center, and he is also heading KM Hospital. So I actually hand over the mic to Dr. Duseja and Dr. Akash to carry over the proceedings.
So thank you, Dr. Nijavan, first of all, from both of us for inviting us for this, restarting the master class, which you rightly said were very, very popular during the COVID times. And we hope that this will actually be a very good teaching and a learning exercise for every one of us. And as you rightly said, I think to open this innings, I think we have none other than Professor Sarin, no better person than him, and Dean of Hepatology and the Dean of Portal Hypertension, and he'll be covering us, speaking to us on portal hypertension. So as you said, I think we will have a break in between to take some questions, and all the participants can keep putting in their questions in the chat box. And then at the end also we will take some questions, and there will be a poll questions in between. So may I request Professor Sarin now to please start his talk on the portal hypertension. Thank you.
Thank you, Dr. Nijavan, Dr. Matthew Philip, and Ajay, and Dr. Akash. It's a tough task of having a master class. I first thought of preparing some cases, but then I thought maybe covering the whole spectrum might be easier than taking just cases, and also will give you some perspective. So please stop me, keep punching your questions. I bring greetings from ILBS and nothing to disclose except that we have very bright residents, brighter than the faculty. I'll take you through some of the areas of basics. Portal hypertension is a raised blood pressure in the liver circulation. It could be arterial, could be venous, but we only have the capability of measuring the venous. So when you have a pressure in the portal vein, which is above the normal, which is 5 millimeter, then you start saying it is portal hypertension. Above 10 is clinically significant. It can also occur in physiological conditions like coughing, bending forward, abdominal pressure while straining at stools, heavy meals, alcohol. But it can be only transitory in physiological conditions. But in disease states, if it is above, it is high. How do you diagnose? You all know that patient has come with a spleen or has ascites and a spleen or has low platelets. Ultrasound shows dilated portal vein, spleen, collaterals, or now fibroscan showing more than 23 kilopascal. Endoscopy shows varices or PSG, not gave alone, and HVPG, which is a definitive but invasive method. So how do you assess invasive and non-invasive? These are very basics. I'm sure you know it, but I'm trying to cover as an intro. Now, how do you measure portal pressure? So one method is to go from the femoral, take the balloon catheter into the hepatic vein and wedge it. The other is transjugular. You go through the neck, heart, and then into the hepatic vein, inflate the balloon. So this is a wedge hepatic pressure. You can also do the pressure by directly puncturing the liver, which will give you intrahepatic, but it is not reliable. But you have a reliable method by going into varices, intravaricial. You can have very reliable by going intrasplenic. You can go through the umbilical vein into the portal vein. These are different methods, but most conventionally, invasive method is transjugular or femoral. So when you have a catheter which has gone into the hepatic vein, you can measure the pressure free or by wedging. Wedge pressure gives you the pressure of the sinusoid of the blood of the tissue. Tissue means fibrous, non-fibrous. So a wedged balloon will give you vascular and tissue pressure. Normally, this wedge pressure is between 6 and 12. Then you have free vein pressure, means the outflow. This is between 2 and 7, hepatic vein pressure. If you take the portal pressure, which is generally 4 to 10, it comes by splenic vein and superior mesenteric vein. And you have about normal pressure is between 6 minus 2. 6 is here, 2 is there. So normal pressure is 3 or 4 millimeter. In portal hypertension, this pressure means wedge minus free is more than 5. And significant portal hypertension, cirrhotic, it is more than 10. How do you do it? If you want, I can run a very brief video. This is to get inside through the femoral root.
Can you see the catheter?
Then the catheter goes in. This is the catheter which we are using as a balloon catheter. It goes inside. And it's very easy for people to do. Then you try and wedge the catheter inside. This is the diaphragm, the liver, and the catheter will go into the right hepatic vein. Once you have hooked into the right hepatic vein, you will be able to, here you have gone into the right hepatic vein. Then you connect all this to a connector and a pressure device. These are the pressure transducers. You have to standardize the catheter. The pressure is seen here. You can see in this patient, these are the ECG recordings. Now you will have 18 by 5. It is the wedge minus free. So just to give you an idea, it is a very simple procedure. Now your balloon, 14 by 14 is a wedge pressure. I'll just skip this for interest of time. So what you do is you bring a catheter in, you inflate the balloon, you inject the contrast to give you a sinusoidal area. These are the sinusoidal grams complete, and it gives you the wedge pressure. Then you deflate the balloon and it gives you free pressure. You do it 3 times. So wedge minus free, 21 millimeter is the pressure in this particular patient. And clinically significant means anything above 10. So I'm trying to tell you, everyone, every resident can learn easily how to do pressure. Like every cardiologist knows, or even physician, how to measure blood pressure. So there are collaterals which very broadly I have explained in this. You have superior vena cava and you have azygous vein. Portal vein, the anterior branch is the left gastric vein. Left gastric forms the varices and drains there. The posterior gastric, which is not seen, forms directly into the azygous vein. I couldn't get a better picture. There are several zones here. It is the perforating zone, truncal zone, and palisade zone. It is in this palisade zone that you have the vessels which are weak. They come out and they can sometimes bleed from here. Now let's look at this concept of causes of portal hypertension. The causes of portal hypertension are prehepatic, means before they reach the liver, and that includes extrahepatic portal vein obstruction. The portal vein is blocked. It makes 10% of all our patients. Pre-sinusoidal, that means it is inside into the liver, which is non-cirrhotic portal hypertension, portal fibrosis. It can be sinusoidal, which is main cause, about 80%, and post-sinusoidal, HVTO and others. So the portal hypertension can be because of the diseases of the liver, because of the blockage of the veins on entry or exit. I hope this part is clear and I know you all are aware of it. So let's understand more about the hemodynamic part of portal hypertension. So in patients where you are going to wedge on this side of the hepatic vein, but suppose the block is here, prehepatic. So the hepatic vein pressure, the balloon and wedge will be normal. In pre-sinusoidal, it will be normal. There will be no gradient because the block is right here. But the portal pressure will be high. So this is the prehepatic or pre-sinusoidal disease where the block is here or the block is here. So the portal vein pressure will be high. Now you take cirrhosis or sinusoidal. Here the blood is coming, but there is an increased tissue pressure. So sinusoidal is high. In these patients, the gradient will be high. Pressure coming and going will be high. Post-sinusoidal, it will not be high. Now the gradient here in sinusoidal as well as post-sinusoidal will be high. Portal pressure will be high in all these. I'll come to non-cirrhotic now in a minute. Non-cirrhotic portal hypertension, I brought it because many people have forgotten it, is a heterogeneous group which is characterized by rise in portal pressure, not wedge, due to intra or prehepatic vascular lesions. Prehepatic or intra. And here the HVPG, the gradient will be lower than the portal pressure. And it excludes cirrhosis and Budd-Chiari. Very simple definition. And the causes could be prehepatic. I told you EHPVO, portal vein thrombus, and some syndromes can be there. HEPG is normal, intrasplenic pressure high, intravaricial pressure is high. This group of patients, hepatic causes. This is prehepatic, pre-sinusoidal. You have congenital hepatic fibrosis, you have schistosarcoid, vinyl, and of course, NCPF and IPH. So this is a group of pre-sinusoidal diseases. Several other diseases can be included, but I am not going to stress upon this. These patients, non-cirrhotic, have a spleen, well-tolerated variceal bleeds, hypersplenism, no parenchymal injury on biopsy or on blood tests. You look at a non-cirrhotic, you have the tertiary branches, third order branches of the portal vein. They have small thrombi. As you can see here, the portal vein branches are sclerotic. They are thrombosed here. And the liver may be generally normal. The wedge biopsy, if you take from the surface of the liver, it could be nodular. But otherwise, normally the liver is soft, good. The portal vein, if you look at the biopsy, is obliterative portovenopathy. The portal vein is blocked and many new small channels, aberrant portal veins open up. Professor Nayak gave the term obliterative portovenopathy. The intima is thickened, aberrant vessels open up, periportal fibrosis occurs, but generally seen only in a resected specimen. And if you look at ultrastructure, the space of disc collagen is deposited. You look at the ultrasound, it's a very simple but good picture. Here, this is the portal vein. But this is the lumen, this is the wall. The wall is thickened, and a simple ultrasound, you can find out periportal fibrosis in these patients. So where is the disease? In a normal person, you have portal vein, you have sinusoids, and then you have a hepatic vein exit. In NCPF, you have thickening of the inflow of the portal vein. So portal vein, tertiary, quaternary branches are thickened, thrombosed. Then there is a sinusoid, which is also thicker. But the post-sinusoidal is normal. So the disease is pre-sinusoidal and perisinusoidal. So there is a gradient between the spleen and the liver of about 9 millimeter, and between the sinusoid and the wedge area, again there is a gradient of 6 millimeter. To understand this, this is a disease which is typically a venopathy. It's a disease of the veins, not of the parenchyma. So now let's compare cirrhosis and non-cirrhotic. In a cirrhosis, the filled dot, let's say the wedge pressure is 20. So intravaricial pressure, which reflects portal pressure, is also 20. But in non-cirrhotic, the wedge pressure may be 20, but the intravaricial pressure may be intravaricial pressure is very high, but the wedge pressure may be very low. So in non-cirrhotic portal fibrosis, when you see intravaricial pressure is 20 or 30, wedge pressure is 8, 10 or 12. So high variceal pressure is reflective of portal vein pressure, but wedge pressure here is much lower. So NCPF and IPH are distinct entities. They are separate disease syndromes. Portal hypertension is the primary event, unlike in the West, PSVD and others, which includes both portal hypertension and non-portal hypertension. I'm giving you the Indian perspectives, the Asian perspectives on NCPF and IPH. The etiology could be infections. There could be metal toxins like arsenic and others, and you have immunogenetic basis. So in this experimental model, you inject into the gastrosplenic vein in a rabbit repeated injections of endotoxins. By giving injections of endotoxins, you can produce a similar picture. In them, portal pressure goes up, splenic weight goes up, but liver histology, there is no evidence of cirrhosis. So this is non-cirrhotic portal hypertension, portal fibrosis, where endotoxins itself can produce portal hypertension. This is to show you, and this is a very important slide for understanding, this is time in minutes. You have injected here the endotoxin. When you inject endotoxin, which happens every day, blood pressure goes down in 15 minutes, but portal pressure goes up. So with endotoxemia of portal vein, portal pressure goes up. Why does your patient bleed? Portal hypertension patient bleeds because of endotoxemia coming from the bowel. So let me summarize this part of rather forgotten diseases, NCPF and IPH. It occurs in 5 to 20% of all portal hypertension. These are well-tolerated bleeds. Patients come with large spleen and anemia. Liver functions are normal. Biopsy may show obliterative portovenopathy. There are two gradients, pre-sinusoidal, perisinusoidal, and of course your treatment is same and prognosis is good. I'll stop here and wait for questions.
Doctor,
Thank you very much, sir. I think so. We break for maybe 5 minutes and take some of the questions which have been put in the chat box. Dr. Shukla, would you like to take some questions here?
Yeah. So one of the question which is asked is, can cirrhotic also have massive splenomegaly up to 30 centimeters or so?
Rarely, because the farther away you are from spleen, smaller is the spleen. Let's say Bhattacharya, smallest spleen. Extrahepatic portal vein, larger spleens.
Right. So we also have a question from Shravanti Devireddy from Trivandrum. She has asked, practically, what is superior, endoscopic or traditional HEPG?
Well, that's a question which can be answered when there are trials of doing both of these. As of now, endoscopic may be less reliable because there is influence of anesthesia and very few people can do it reliably. I would do HPPG.
Right, sir. So there's a question from Chennai by Dr. Nataraj Murugan. What is the role of liver stiffness measurement for staging portal hypertension and clinical decision making?
We'll come to it.
Yeah, I think, and the last question is mechanism of ascites in non-cirrhotic portal hypertension.
I'll come to it.
Okay. I think other than that, somebody again has put in a question about the role of EUS in the portal pressure measurement. Maybe I think we'll come to that maybe later, sir. So, but then one question which I thought maybe, because since you spoke about the non-cirrhotic portal hypertension, how about, sir, this new entity of PSVD or portosinusoidal vascular disorder? If you can just clarify on that.
Yeah, I thought of keeping a slide, but it was late 3 a.m., so I couldn't locate the slide. In very simple terms, the PSVD is a portosinusoidal vascular disorder, and any disorder they have included with or without portal hypertension. Number one difference is you may have no portal hypertension and still PSVD. To all diseases like ALD, MAFLD, viral hepatitis, anybody it also can have PSVD changes. Third, liver biopsy is essential for diagnosing. There are three specific features. The specific features include that patient should have obliterative portovenopathy, which as it is hardly seen. Then The spleen size, these are clinical syndromes, spleen size should be more than 13 centimeters. So I think it's an exciting term, but probably it is going to be ACLF of West, include everything which is not there. So I think I may try and locate a slide at the end of it and show you, if possible, the differences. But I think it's a new entity. We should not discard it, but we should also look into merits and demerits of this. It includes NRH, it includes incomplete septal cirrhosis, which are disease entities in themselves.
Sure. Thank you very much, sir. I think the last question before you restart is somebody's asking about flow-dependent portal hypertension, if at all. Say somebody having a large splenomegaly of some other etiology, what happens to the portal pressure? What kind of gradient will they have? So if you can just clarify on that.
It's a very, very important question. In a normal liver, you can increase portal blood by 7 times. Let's say you and I eat heavily and some of you may drink heavily, portal blood flow increases 3 times, but no portal hypertension. You can do it up to 7 times. But if there is a fibrotic liver, 1.5 times increase in portal blood flow will raise portal pressure. This is the concept of ACLF. ACLF, you have cirrhosis already, and then you have either another insult of alcohol or so, and the portal blood flow increases acutely, and you get ascites. So, flow-dependent portal hypertension is context-dependent. Let's say you have a very large shunt between an artery and a vein, splenic artery and vein, or a fistula, you are unlikely to develop portal hypertension unless it is more than 7 times normal.
Professor Sarin, Dr. Doseja, Professor Sarin, when do you want the poll questions at the end or now?
Maybe at the end.
Yeah, I should be.
People are tired out, we'll ask questions.
So, sir, there's been a tremendous response. Our chat box is flooded with questions, over 50 questions already. So I would encourage everybody to keep on asking questions. I think that gives us a fair idea of what people's thoughts are and where their queries lie. So please keep on asking questions, and we'll try to cover as many questions as possible. So
I purposely took non-cirrhotic in the beginning because many of the younger people might not have. So I'll restart now sharing my screen.
Sure, sir.
And go to the next. Extrahepatic portal vein obstruction, EHPVO. It used to be every resident would get 1 case of EHPVO or NCPF. You may still get it. EHPVO, if you look at it, is a normal or near normal because the block is here and your wedge catheter is on the other side. So you will have near normal or normal HVPG. Spleen is large. Closer to the spleen, the block, bigger it is, except in NCPF, where it is disproportionately large spleen. Absence of parenchymal dysfunction, normal AST, ALT, albumin, INR. We generally will only take portal, but it can be associated with mesenteric or splenic vein thrombus. Isolated splenic vein or mesenteric thrombosis are not part of it. So generally in India at least, or in the Asian continent, at young age, these patients may have spleen, but may develop between 1 to 18 years. Spleen, bleed, hypersplenism, growth failure, biliopathy. Between 18 to 40, variceal bleeds, recurrent, biliopathy can become symptomatic, and parenchymal extinction may start. If you see a patient, and I remember having seen long ago a patient of 63 years with cirrhosis diagnosis, but the patient had massive ascites, could not even be transplanted. So this is a journey of parenchymal extinction, development of ascites, symptomatic biliopathy, and other diseases. How do you diagnose? Normal liver function, endoscopy showing esophageal, gastric, and anorectal varices. I think the PGI group Professor Duseja, Professor Chawla had shown 90% of these patients may have anorectal varices. Doppler will show cavernoma, and liver biopsy, which I generally believe is necessary, can be very helpful, especially an adult with a EHPVO. Now, portal cavernoma, here is the splenic vein, superior mesenteric, no portal vein. So you have collaterals which are portoportal collaterals from this vein to this vein. When these veins are very dilated, they will actually compress the bile ducts. So the bile duct can be wavy, this is biliopathy. Then you have an artery which will supply more blood. So it is a human model of an animal rat model called partial portal vein ligation. In partial portal vein ligation, you block the portal vein, put a needle on the portal vein and tie a thread. That is a partial portal vein. When you block the partial portal vein, portal hypertension develops. In a bile duct model, when you develop a common bile duct ligation, this disease. So the EHPVO is a model of partial portal vein ligation and partial bile duct ligation. So in biliopathy, what you will see, this is the pancreatic duct, this is the endoscope. Here you see there is a wavy dilated common bile duct, and you also have in this patient a stone here, a very dilated left hepatic along with a stone formation. Now this is for you to poll and say, is this a patient of cirrhosis or EHPVO? You can say EHPVO or cirrhosis. Please put on the chat box. Here is a shrunken liver, massive ascites. All right, second case. Here is a patient who has a large spleen. The question here is, it is obvious that there is no portal vein. All that is replaced. The gallbladder is surrounded by gallbladder varices. These are all gallbladder varices. The portal vein is totally gone here. The question here is, does he have a splenic vein thrombus, SMV thrombus, or a portal vein? So those who say it is portal vein, say portal vein. Others may say it is a complete block. All right. So now I'll give you the answer right here. In this patient, this is a cirrhosis. This is a EHPVO. Looks like cirrhosis. And here you might even see there are some thrombi, but we do not know what the image is like. But this is a classical patient. I'm sorry, we should not have given the name, but it just came up. Apologies. But he's 66 years old. So at this time, parenchymal extinction. Here again you see this is a portal cavernoma. Here the splenic vein is seen, and this patient is a EHPVO, elderly. Here this patient has no splenic vein. There is SMV is also thrombosed, and the whole area is replaced. This is common with EHPVO. Now the third patient, why the names are there? Again is an EHPVO, but you can also see that these vessels are going up and they are making your coronary vein. Parenchymal extinction is seen at above the age of 40 in about 1 in 5. They will come with ascites. And longer the portal hypertension, more is the extinction. They now get deranged liver function. They have biliopathy. These are very sick patients. You can't transplant, you can't do TIPS, and biliopathy itself needs a separate lecture, but I'm not covering that part. These patients of non-cirrhotic and EHPVO may have a common origin. At birth, there can be a severe infection in the umbilical cord, and this can lead to a thrombus in the main portal vein. They will develop EHPVO. But if there are minor, small, mild infections in the childhood. They develop chronic antigenemia, phlebosclerosis, maybe added by arsenic and copper in some parts of India. They cause pre-sinusoidal fibrosis, pre-sinusoidal resistance increases. This is NCPF, this is EHPVO. We have tried to propose a unifying hypothesis. So I'll summarize EHPVO. Chronic EHPVO generally in India has portal hypertension. These are in children. They are well-tolerated bleeds. They have anemia, spleen, 2 plus not 3. Because of the early origin, the blood to the liver, IGF-1 is low. There is a growth retardation, at least in 50%. They are stunted, 50% pass. So if you see a patient of EHPVO, if you see a patient of portal hypertension who is 18 years and is growth retarded, the first question you can ask, "Bhai, tumhari daadi mooch kab nikli? When did your menses start?" Simple thing. He says, "Sir, daadi mooch to abhi 18 ka ho gaya, nikli nahi." Your diagnosis can be he has EHPV or hasn't started menstruating. Or patient is growth retarded. उसके दो, एक भाई और एक बहन है, बहन लंबी है, भाई छोटा है. So this guy has a pre-pubertal disease, not a post-pubertal disease. So this will define EHPVO very well. Then you have biliopathy. Patient comes with cholangitis, has a dominant stricture. You have to stent it. If there is a stone, remove it. If you can't, on repeated times, you can put a metal stent. But generally, early shunt surgery is helpful. Late may not help. Then the duct is thick. And a hepaticojejunostomy sometimes is needed. Some centers in the world can do a rex. Sorry, this is not a shunt. It is a rex bypass. Please apologize. The left branch of portal vein is connected to the mesenteric. It is called a mesenterico-portal bypass. Left portal vein is connected to the mesenteric vein. And that is growth retardation can be corrected in them. All those who have got shunt surgery, conventional shunt also can improve their growth. Of course, you will manage them with band ligation or glue. So now I close this part of EHPVO and we can take some questions and comments.
Okay, I think thank you very much, sir. So again, lot of questions in the chat box, but maybe we'll select out few and maybe we will move on. I think a lot of questions which people are asking about the mechanism of ascites in NCPH, both EHPVO and NCPF. I think probably you said that maybe around 20% of them can have that, but then everybody's asking about the mechanism. Does it happen only after a bleed? Can it happen without bleed? And if yes, what is the relation with parenchymal extension? I think a lot of questions, so I'm just summarizing it into one.
It's a very good question, and I'm happy people know portal hypertension to that level. I thought people have forgotten. Students are smart. So if you do a patient who has ascites in a portal vein EHPVO, our group of patients, the portal pressure, wedge pressure is normal. It will be 3 or 4. You do a biopsy. The biopsy is also no fibrosis or just mild fibrosis. So why ascites? 60% of those who have portal vein thrombus also have small branches of hepatic vein block. It has not been published, but Dr. Wanless has reported that this is a continuum. Because the less blood is flowing in portal vein, volume, the flow rate is low. So the exit, the hepatic vein gets blocked. 2, there is a lot of perisinusoidal leak, the lymphatics. In the sinusoid, from the portal vein, the blood goes to the central vein. Bile flows in the reverse direction and the lymphatics flow in the reverse direction. So zone 1 to zone 3 is generally blood. Zone 3 to zone 1 is bile and lymphatics. In these patients of EHPVO, the lymphatic pressures are extremely high. You don't see lymph in the ascitic fluid, but very high lymphatic pressures are there. So the three mechanism: part blockage of hepatic vein, part increased flow in lymphatics, and part is small volume liver. It is small for flow liver now, and there is therefore ascites. Like you have a transplant, and this is a small for size graft, more blood and ascites.
हाँ, ये जो questions है, ये जो मैं dashboard पे देख रही हूँ.
Nisha, can you please mute yourself? Okay, so I think thank you very much, sir. I think these two additional mechanisms would really be, very educative about the lymphatics and the hepatic venous, block, which you said. So the other question, again, a lot of people are asking about the possible thrombophilia workup in EHPV or NCPF. Should we be doing an all or select it out, or how do we do it?
Yeah, the thrombophilia workup is useful in a patient who has cirrhosis and portal vein thrombosis. I think in our setup, to put an expensive thrombophilia workup of a few thousand, as a clinical part, as a research you should, but as a clinical part, it is not going to help. I'll give you an example. We worked every single newborn baby with umbilical sepsis. We took it from the gynae ward. 25 children with umbilical sepsis. And I used to do Doppler, thinking that umbilical vein catheterization or sepsis will cause portal vein thrombosis. And I followed them for 2 years. We published in not one of them developed portal vein thrombosis. So I think the most important part is the way the umbilical cord is handled. It is a trauma rather than infection as a cause or a genetic. Yes, they have a predisposition, but for clinical workup, no.
Sir, I have a question here. Do you think there exists a condition where you have a congenital absence of portal vein and just a cavernoma? And
I am sure you are referring to Abernethy, congenital malformations of the portal vein, which I excluded them. I didn't even think I should include. But yes, type 1, type 2 are both there, where the portal vein either does not exist and only liver biopsy will show you that there are triads. The other is where portal vein goes into the IVC directly. Congenital malformations of portal vein can produce hepatic encephalopathy, but not as variceal bleed or collaterals.
no, sir, I didn't mean Abernethy. I was saying that what cavernoma we see, could it be a congenital variation in the portal vein, in the embryogenesis? Is it because we have not really seen the evolution in children the way we expected it to in all the longitudinal studies that we have?
I agree with you, but it will require a very large cohort. But cavernoma can form in 6 days after portal vein thrombosis. So if a child at 1 month or 2 months get a thrombus, he will develop collaterals in about 6 days' time, and cavernoma can form. But
So,
I don't think
sure.
cause.
So there are a lot of questions, I think, regarding the management, EVL versus beta blockers and all that we will cover later. But also some questions about the non-invasive measurement of CSPH, including LSM, SSM, splenic stiffness and all. So I'm sure you'll be covering that later, or we discuss it now.
I can discuss for non-cirrhotic here.
Right,
so
sir.
maybe we will do it later when we come LSM and SSM later.
SSM, okay, sure.
We'll do it later.
So what is
Okay.
the mechanism of growth retardation in these children, sir?
Yeah. So if you take an animal, don't mind my saying, if you take a rat and do partial portal vein ligation, the rat, which as an adult should become 300 grams, becomes 200 grams. 2, there is testicular atrophy. 3, there is muscle atrophy. These are typical what you see in a EHPVO human being. So there is a portal vein which brings you all the nutrients, maybe from the bowel, all the growth hormones, especially IGF-1 growth hormones, and it brings a lot of and from the splenic vein also, from the pancreas, it brings all the other. So when you have a EHPVO, the positive hepatotropic hormones or nutrients are deprived. So the growth retardation, prepubertal, is because of this. But the growth hormone levels are not low, but IGF-1 levels are definitely low.
Sir, there is a Matthew Philip here. Sir, there is a question by Moise on how to differentiate NCPF versus child day cirrhosis without a liver biopsy in clinically and lab parameters.
Yeah, simple. A disproportionately large spleen in a young man with repeated attacks of variceal bleed without ascites or decompensation with a normal liver is more often seen in NCPF than in a cirrhosis patients. 2. In such a patient, you will have a liver stiffness which may be less than 10, maybe, but a spleen stiffness may be close to 70 or 80. So a disproportionately high spleen stiffness and variceal bleed without decompensation will favor this. But I would say never diagnose without a biopsy or HVPG.
So just quickly before you move on, again, lots of questions on this. Again, I'm combining about the adult onset portal vein thrombosis. Should we call it as EHPVO, say, for example, secondary to chronic pancreatitis or some other etiologies? And is the entity something like segmental portal hypertension in this kind of setting still valid? I think a lot of questions on that.
यार बड़े होशियार लोग हैं यहाँ तो students are masters यार. What is this master class? They are teaching us, asking. This is good. Left-sided portal hypertension is pure splenic vein thrombosis. It's very well described. Remove it and treat it. But in an adult with portal vein thrombosis, I think EHPVO was a generic term given, extrahepatic portal vein obstruction. So it is extrahepatic. In an adult, you will have in a cirrhosis generally intrahepatic. So PVT is a term which is often used for intrahepatic portal vein obstruction. To differentiate the two, I would say if there is an acute portal vein thrombosis, you may refer to a paper, consensus paper, which we published in gastroenterology, I think October 2016. A simple classification. It will help you. In an adult, portal vein thrombosis is generally acute with or without cirrhosis. It is not EHPVO. EHPVO, as we understand, is a disease of children in the Asian continent, not in adults.
So thank you very much. I think we can move on and we'll take questions later. Thank you.
Now I will not take too much time. I just made these slides for the interest of people. We will stop when the time. Now we are on cirrhotic portal hypertension. This is what you see every day. Now this is a big syndrome. You have a patient who has got high portal pressure because of resistance. It can come as ascites. I'm not discussing. That is a separate topic. It can come as a hypersplenism, splenomegaly. It can have hepatic coma. It can lead on to deranged liver functions. Kidney, I'm not discussing HPS, PPS, and all this area. I'm just trying to cover some parts of varices and variceal bleeding, a little bit of esophageal, probably none of gastric. This is a diagram which will give you an idea that when the portal blood goes and there is a resistance, which is the first thing. To overcome the resistance, the blood flow increases. So blood is not allowed to flow. To overcome it, more flow, overcome it, more flow, and then it does not get in, and you will have bypasses. So the famous Ohm's law, total pressure or pressure is equal to resistance and flow. Now we have cirrhotic portal hypertension, where there is a structural and a dynamic component. Structural is fibrotic liver or a cirrhotic liver. Dynamic component includes intrahepatic non-parenchymal cells. Now, the intrahepatic non-parenchymal cells can be stellate cells. You can see that stellate. They are 5% of all liver cells. They store vitamin A as a nutrient and a communicator, and they are generally silent. Now, if there is an insult like alcohol or anything else, they will become active. They become fibrogenic, pro-inflammatory, proliferative, ek ke do, and they become very contractile. So these are active hepatic stellate cells. Now, what do they do actually? So I showed you the sinusoidal cells. Here is the LSEC, and then you have the stellate cell. Now, hepatocytes, this is the membrane, the microvilli of the hepatocytes. You have the sinusoidal cells, and then you have the endothelial, and then you have the stellate cell. I'll not go into much details into this, just to tell you that here you have a production of nitric oxide, which is because of increased blood flow. So, to overcome the resistance, more blood. The more blood will give more nitric oxide. So, stellate cell must relax. If it relaxes, nothing more will happen. Unfortunately, there is a relative deficiency of nitric oxide. The flow is more, the stress is more, so stellate cell does not relax. And it will start into contraction, and these are also produced by endothelins. You have much more of norepinephrine coming into this, which adds to contraction, leukotrienes. So if you knock out endothelin, COX, or norepinephrine, or you increase nitric oxide, your stellate cell will be happy. You will not have further contractions. Lymphatics. I've added this new area because I just want to, this is a hugely new emerging area. So one more time, portal vein drains into the central vein. The bile flows into this direction. And you also have the lymph which will flow into this direction. So the lymphatics are surrounding this. You have two types of junctions. You have button-like junctions and zipper. So button-like will keep on holding the lymphatic here, and they will take it into the hepatic regional lymph nodes, which has now smooth muscles, and then it takes into cisterna chyli. In a patient with cirrhosis, you have 3 to 5 times more lymph production. Your blood flow is increased 2 times, 1.5. Lymph flow, 3 to 5 times more. So what happens? Normally, we are only talking of portal hypertension in cirrhosis, vasodilation, hypovolemia, sodium water retention, and fluid leakage. We have to understand at the same time, because of increased resistance and pressure, there is more lymph production, 3 to 5 times. There is a weeping liver, and there is an addition of fluid through this mechanism from the capsule. Now, it is important to know angiogenesis is done by VEGF-B and VEGF-A. For lymphangiogenesis, we have VEGF-R3. All the new drugs are now diverting to how to stop lymphangiogenesis. One other interesting part which you may enjoy is the role of Paneth cell. You all are GI people probably. you know better than me, the villi. Now here you have the enteroendocrine cells, your enterocytes, goblet cells. Here you have stem cells which make new intestine, and the Pennant cells. The Pennant cell actually interacts with the microbial peptides. It is the pacemaker for the blood flow. All the blood flow to the liver is directed, portal hypertension is directed now by Pennant cells. So the new generation of drugs will include Pennant cell dependent drugs. I'll stop here to make for questions on the pathogenesis of portal hypertension or lymphatics. So I'll stop here for a period of 2 minutes.
So, Dr. Akash, can you take some questions?
Yeah, so I actually didn't find too many questions on the pathogenesis part, but I actually wanted to ask you, ask your comments on Professor Iwakiri's work on lymphatics. So would you want to comment on that, sir? Because I think that is very exciting.
Yeah, Iwakiri from Yale, you have rightly quoted, is a frontline worker on the lymphatics. And her work has shown how down-regulating the VEGFR3, that means the receptor. What happens is, anything you eat or the drug you take is absorbed from intestine and goes to the liver. So all drugs can cause drug toxicity. But if the drug is not metabolized in the liver and goes from lymphatics, so you have eaten, it has gone to the intestine. From intestine, it is absorbed into lymphatics and goes away without going to the liver. So the new generation of drugs are directed to take to VEGFR3, which is typically in the intestine, in the lymphatics, and does not need liver. So there is no drug toxicity into the liver.
Right, sir. Thank you, sir. So I think we can continue.
All right. Now we come to the questions related to diagnosis, invasive and non-invasive. I briefly told you HPPG. We'll cover the non-invasive. So invasive way is a liver biopsy and HPPG. In biopsy, remember, if you have small nodule and thick septa, this is stage 4C cirrhosis. You will have more portal hypertension, higher pressures. If you have large nodule and thin septa, it is stage 4A in liver biopsy. You will have low portal pressure. So, fibrous septa thickness and size of nodule 4A is a small, thin fibrous tissue, large nodule. Now, in HPPG, 10 or above is considered as clinically significant portal hypertension. But can you do by biomarkers? I'm not going into details of biomarkers, but just to tell you, you know about APRI, you have the ELF score. The Siemens are bringing this up. If it is above the 11.1, it is considered as clinically significant portal hypertension. If it is above 9.7, it is still considered high. You have 1 millibrand factor antigen, which is more than 315%. I'll come to it again. It is considered CSPH, or an ICG retention, which is more than 15%, is also CSPH. We are quite used to liver stiffness and spleen stiffness measurement. I'll come to the real values in a minute. So this is BAVENO 7. Most of you must have seen it. If the liver stiffness is more than 25, it is CSPH. If it is more than 20, but platelets are low, less than 150, again it is CSPH. If it is less than 5, it is normal. You can exclude. I would also say up to 10, it will be quite less likely to have advanced liver disease. So the gray zone remains between 15 and 25, especially if platelets are good. So if platelets are above 150, maybe in this range from 10 to 20, you do not need an endoscopy. But if the platelets are lower, any of this area, I would say between 15 and 25, you should do an endoscopy or a liver biopsy. Now, the liver stiffness increases with fibrosis. But portal hypertension, it does not reflect directly. LSM of above 25 or platelets of less than 150,000, sorry, not 100,000, it is a significant portal hypertension. Spleen stiffness, which is through a new fibroscan machine 630, it directly reflects portal hypertension, the portal pressure. It is due to congestion and other changes. But remember, if there is a linorenal shunt, if there is a portal vein thrombosis, or if there is an additional ascites, these patients, SSM is not going to help you. So ascites, PVT, or a large shunt. Otherwise, a liver stiffness above 25 is very reliable for CSPH, and a spleen stiffness of more than 50 is CSPH. Now, what is CSPH and what is the relevance for it? This is your blood pressure machine, 0 millimeter, 5, 10, 12. Now, normal is less than 5. We have seen it. Now, subclinical is not visible, means no bleeding and others, is 5 to 10. And clinically significant is ascites and bleed and others. I'll discuss briefly subclinical. This is an area which very few people will know. So our aim is that we should reduce portal pressure. I mean, like somebody has a BP of 120 by 80 and he becomes 150 by 90. Will you accept? No. You will actually start working from 130. So this is a data which I want to show. Patients who have got an HVPG of 20 or above, like this, in 2 years, half of them will decompensate. HVPG between 6 and 12, not very high, 11% will decompensate. But if you have now between 6 and 8, and 9 and 10, even between 6 and 8, 9% can have decompensation at 2 years. So my thinking is we should not wait everyone to have CSPH and have pressures about 10. You may start looking at them earlier. Subclinical is not so benign. Now, acute bleed. Bleeding varices. In this patient, this is an AGA teaching slide. There is a nipple sign suggestive of a very recent bleed. And this is an active spurter. Active spurter means portal pressure is above 16. HVPG is above 16. How do we manage these patients? A lot of modifications have been done. I'm giving you only the brief thing. So door to needle time means patient has come and you have started Turley or Somat within 30 minutes. Our average is about 7 minutes or so. PPI, antibiotics, NAC, and hemoglobin around 8. If there is a patient, you should try and do endoscopy within 6 hours. There is enough data to say don't do it, but they are from the West. But if you can do it, why don't you stop bleeding? Stratify the patient based on child's risk score and a partial bleeding risk score. I am not having time to give into details. Now the patient has stopped bleeding. After EVL, you may continue the Turley or Somat for 2 days and then go on for EVL. If there is a persistent bleeding or there is failure to control bleeding, then you have a rescue therapy. You can do decompress by tips, compress by Denisella stent, or block the shunt. This is the trend in ILBS, not to publicize. We close to see patients who have got about 900 to 1,000 patients. So over years, our mortality has slightly decreased, but still mortality is about 13% or so. This is 6 weeks mortality. Now here is a patient. He's a difficult patient. He came CTP 11, MEL 23, routine EVL is done. आप देख रहे हो varices हैं, भाई band लगा दिया अपन ने. Now, after 12 days, patient comes with a bleed. There is a post-EVL ulcer, very often seen. So what did they do? They did a glue therapy into this, injection of glue. But after glue, again in 4 hours time, patient has started bleeding. So how do you manage such a patient? Because his child C. So in such a patient, there are opportunities of putting a Danicella stent. The stent, you can put a Sangstecken tube, but this is generally for varices which have not EVL done. Or you can put a Danicella stent, which is a stent which you can place with or without endoscope, with or without fluoroscopy. And this self-expanding stent is placed in the esophagus. It can control bleeding, and you can take it out subsequently without any difficulty. It is expensive. That is the whole issue. Should we do TIPS? TIPS is generally done when the pressure is more than 20 millimeter. So in our setup, any acute bleed, you will try and do an HVPG. If it is above 20, we will tell the patient. But if you do TIPS within 8 hours or 8 to 24 hours, if you do within 8 hours, hepatic ischemia is less, survival is better. So TIPS can be used preemptively to prevent second bleeding or as a rescue therapy. What does BAVENO 7 say? In acute bleed, FFP don't give. Platelets, fibrinogen don't give. Discontinue anticoagulants until hemorrhage is under control. And in GOV2 or IgV1 or ectopic BRTO, and TIPS can be combined with embolization. I would like you to think acute bleed requires an expertise and you require a mentor to manage. I'll stop here and then wait for some questions on acute bleed and management part.
Thank you, sir. I think again, some questions on LSM and SSM have come in. So, again, to put it all together, and people are asking about that. We do have, now more clearer algorithms of using LSM for predicting CSPH and cackled and the rule of 5, which BAVENO 7 gave and all. Do you have similar kind of guidelines for using SSM? And the second question would be that we need a special kind of probe, 100 hertz probe, to look at the splenic stiffness. So this question is from me. I mean, no, a lot of people have ultrasound machines which would have 2D shear wave elastography. So how good is the data of measuring splenic stiffness with 2D shear wave elastography versus the transient elastography or the fibroscan?
The SSM as a predictor of portal hypertension is quite clear. Less than 32, no portal hypertension. Above 50, or I would say 51, there is varices needing treatment, VNTs. In non-cirrhotic, the splenic stiffness above 70 or so, it's not defined, is about required. And patients who are likely to rebleed or bleed in the cirrhosis group would be above 70. So let us say 30, 50, and 70. Less than 30 generally, although BAVENO says less than 21, in my feeling, less than 30, no portal hypertension, significant. Above 50, 50 and above, significant. For a bleed above 70. For non-cirrhotic, above 70 with a normal or near normal LSM. Now, the shear wave elastography is very good. We use it sometimes when we are unable to get the LSM because of thick wall, obesity, or fluid or something. It has not been standardized for spleen, so I would not be comfortable in guiding you. I would say a better rule is platelet. If a platelet is less than 100,000, that's a bad guy. He needs treatment or so.
Sir, two more questions which have come up related to the bleed management. One is, what is the role of EUS with coil and glue? And when to go for radiological interventions like BRTO?
Yeah, I've not covered the gastric viruses because it has already become too long. But I think gastric varices, if the patient has got a large shunt and has a hepatic encephalopathy, BRTO can be tried, but it has its own problems, PARTO or BRTO, because it increases portal pressure. The patient, if he has large varices, grade 3 can bleed. No varices or small varices is okay. Patient with gastric variceal bleed, TIPS is not advisable because the portal pressures generally are less than 10 or 12, so gradient is not high. Patients go into HE. Coil embolization, yes, it's a very fancy thing, expensive, and very many people are using. But believe me, in our experience, at least in my experience, I have never found a single patient where it has any added advantage over a carefully done glue. The reasons for gastric varices glue failure are the following. You have picked up a vein and you have not adequately, the 2 ml rule is not very, sacrosanct. You can go up to 3 ml or 4 ml, but go slow. Don't have to inject very fast. Otherwise, the glue will go away. And secondly, you can keep your 2 or 3 injections in a large varix, so you can actually obliterate it very well. Yes, glue will fail if there is portal vein thrombosis like EHPVO. 1 out of 3 will bleed. Hence, with all respect to EOS guided coil embolization people, which is technically exciting and like a spirited warrior, it is good, but I find no added advantage of doing this. Yes, you can feel that this is blocked, but obturation is not equivalent to success.
So again, there was an earlier question about EUS measurement of portal pressure gradient for as a modality for portal hypertension, because you showed that figure about the non-invasive and the invasive modalities. Where does EUS fit into today's era?
Well, EUS guided portal pressure is a very, very good area for work. I would feel it has a place because you're directly entering the portal vein. So this has a huge advantage. You can do portal blood sample. You can take the pressures directly. My only concerns are limited exposure, risk of bleeding, and also effect of anesthesia on the portal pressure. But it's an evolving area. It will come, and it has already come there.
So there are 4 very practical questions which have been asked. So one is, when a patient comes with acute variceal bleed, do you give bolus terlipressin or you give terlipressin infusion?
I removed that slide. That study has been published. Bolus versus continuous infusion. Bolus, you will go up to 8 or 12 milligram per day, 2 milligram every 4 to 6 hours, so which has side effects. In the infusion, you will go maybe 4 milligram throughout the day, so less side effects. To the continuously, the half-life of terlipressin is 23 minutes. So infusion will give you persistently good terlipressin levels. And 3, It also, infusion is also helpful for renal flow, so which is good. So I think infusion better.
Yeah. Second practical question which has been asked is, patient has been banded, patient is on ventilator, you want to start feed early. Can you put in a Ryle's tube?
Yes.
Then if you have a endoscopy for a patient who has come with a bleed, you find esophageal and gastric varices. There are no stigmata of recent hemorrhage in either of the two. Will you tackle gastric first, esophageal first, or both of them together?
If the gastric varix are high risk, means more than 20 millimeter with red color signs, irrespective of the stigmata, I would handle both. I would do also the gastric varix as well as the esophageal. However, because 8% risk is there, if you only do esophageal, the bleed from gastric varix is 8% in such patients. If you have small varices gastric, I wouldn't bother.
So we are left with maybe only 10 or 12 more minutes to conclude this, but then two more questions in the special population which
one
was asked
question
earlier, which I thought would be very important. One is people are asking about the uh, management of portal hypertension in pregnancy. Either with bleed or without bleed, you find varices, cirrhotic or non-cirrhotic, beta blockers versus EVL. I think that's one question.
हजारों ख्वाहिशें हैं, हजारों ख्वाहिशें कि हर ख्वाहिश को दम निकले. अभी मैं बीटा ब्लॉकर पे आया ही नहीं. चलो.
ठीक है, sir. I think the EVL and the beta blockers we will cover maybe in the last segment. But Dr. Nijavan has a question before that.
I have a question, sir. Okay, what is the correlation between shear wave elastography and transient elastography? Because there are some high-end machines nowadays with the radiology department. So can they measure, and fibroscan machine is not required?
The disadvantage of fibroscan is sometimes the thick wall of the, and the probe. Many people don't have an Excel, so it doesn't go that deep. An Excel, although as good as this, but may give you 1 or 2 kilopascal less. The disadvantage of shear wave is it has a very narrow range. Fibroscan has a range up to 75. So it is very good because of a larger scale. Both have their place. My preference is a fibroscan, not a shear wave. Firstly, I can do it, and I can do it many times.
Sir, I think now we can proceed with the talk.
Yeah, I think because we need to finish it.
I will try and cover, if at all time permits. I won't overshoot. So now I come to a little bit of concept on modulation of portal pressure. As I showed you, endothelin is more, the thromboxane A2, the leukotriene, they all are vasoconstrictors, and norepinephrine is more. And vasodilator, nitric oxide, despite excessive production, is still relatively low. So what we need is beta blockers to block it, inhibitors of ACE, thromboxane A2 inhibitors. So norepinephrine has 3 kinds of receptor, beta 1, beta 2, and beta 3. Now, we are not bothered much about beta 1, but remember, when you are giving some of these drugs, they can have effect on heart. We are giving non-selective blockers, so they will affect all the 3. What will they do? They will decrease the chronotropic and inotropic function. So a patient who is on beta blocker and he bleeds, uska heart वैसे ही कमजोर है, वो बेचारा pump ही नहीं कर पाएगा. So remember how to manage bleed on a beta blocker. Now this non-selective beta blocker will decrease portal pressure because of this, because of relaxations. It decreases risk of bleeding, translocation, development of SBP. But it also will decrease your renal perfusion. So don't give it in patients with ascites or advanced. The window hypothesis, don't try and open it too late. The wind will blow you, or risk of developing HRS. So cardiac output, decreased, renal perfusion decreased, risk of... So having knowledge of all this, we start. Now, beta blockers can be given in pre-primary. Pre-primary means patient has not actually developed varices. They are small varices, and you can give carvedilol in this. You can prevent decompensation. You can prevent first varicose bleed. There is enough data. You can prevent rebleed. You may actually help in portal hypertensive gastropathy. For gastric varices, there is level 3 evidence. Carvedilol is better. Now, this study, Predesky study, has shown beta blockers can prevent decompensation in a CSPH group of patients. You can see here, most of these patients were childs A or B, no C, child C. And what they have shown that as a primary composite outcome in patients who have got beta blockers, here placebo, and this is beta blockers. The cumulative incidence of primary endpoint, that is decompensation or bleed, was significantly better. How to assess response to beta blocker? This is a very important slide. I made it early hours of the morning, in the night. Acute bleed, you require 20 millimeter or above and you use tips. HVPG will assess. So how do you assess response to beta blockers? In an acute bleed, there is no way. You can put a catheter, you can give IV carvedilol or oral carvedilol. Carvedilol takes about 10 minutes to 15 minutes, but you don't have time. So in acute bleed, you cannot assess beta blocker response. And generally, terlipressin reduces only 2 millimeter. So none of these drugs, terlipressin, somatostatin, will give you. So pressure about 20, 2 tips. For growth of varices, grade 1 to grade 2 or grade 2 to 3, you reduce portal pressure by 8%, not even 10, varices will stop, they will not grow. In primary prophylaxis, you require 20% reduction because they have already become big and they can bleed. Non-response is actually in 60%, even with carvedilol. Secondary prophylaxis, 20%. Means patient has bled, he already has high pressure. You need to reduce it. For SBP prevention, infection, mortality, 10% reduction. Gastric varix, no benefit. Now, suppose you don't have HVPG, you want to do liver stiffness. It's an evolving area. BAVENO guideline is 20% or more reduction in stiffness or bring it to less than 20. SSM, we have our data, but I have not published, so can't say. Anything which is above more than 10% is good. Or a von Willebrand factor, very easy to do, reduced by 5%. Non-response to beta blockers. So what are your options? 60% will not respond. EVA bread. EVA bread done by good work by Madhumita. So you don't have to reduce pressure, reduce the heart rate. EVA bread blocks the funny channel without, so a patient has a BP of 95 by 60. You can give EVA bread and heart rate is 100. So you can't give beta blocker. Heart rate 100, BP 95 by 60. EVA bread will bring the heart rate to 60. It is as good as giving your beta blocker. You can give statins, although there are good and bad, but we do not give it because of many complications. Metformin for all our beta block, for all our diabetic patients, cirrhotics, metformin, it reduces pressure by 2 to 3 millimeters or so. But we don't have much to choose. You generally will need an EVL in these patients. I have not covered with you a lot of portal hypertension. I'll just give you some ideas on personalized care for portal hypertension. So HVPG is a gold standard, but slowly others. Non-invasive tools are becoming important. Impact of therapies on cirrhosis and regression is our aim. Prevention of first decompensation is our aim. With this in mind, I would stop here. This is a huge area, and I have probably covered only tip of the iceberg. But yes, we'll be happy to have more questions anytime now or later.
Sure. I think, can we have the poll questions now, sir?
Yeah, poll questions.
Okay, Prashant, the poll questions, please. Meanwhile, you take up some questions. Akash.
Yeah, sure. So again, sir, I think so we have the first poll question. So while the people would answer, we will take some more questions. So what is the first poll question?
What is the HEPG in an NCPF patient with grade 4 varices? So half of them have answered 6 to 12 millimeters of mercury. Oh, it's changing by the moment. Sorry. So, sir, can we have, while I think it'll take around 20 seconds
I
for
think
people to vote.
In NCPF, the gradient is never high. It is pre-sinusoidal. So majority of the patients, I would say 70 to 80% would have less than 6. But if they have developed hepatic vein block, they might have between 6 and 8, not even 12. So anybody who says above 16 has not, I have failed to explain him what is NCPF. It's not your mistake, it's my mistake.
No, sir, it is actually coming. Actually, it's changing. People are
But still, if we
But
see
is it
the
increasing?
16 is still close to 30%.
Yeah, it's
Yeah.
increasing.
NCPF portal pressure is high, but the gradient HVPG is normal or near normal.
Yes, sir. Now I think
can go for the
legislation
next
is
question.
picking up.
Only
actually,
32 participants, sir. Bande hi nahi. Slow, right?
There are so many participants, almost 900. See, can we go to the next question then?
Okay.
In EHPVO patient with ascites.
Can we have people voting?
Yes, already there.
So, sir, I think you can start commenting. I think here most of them are getting it correct, I feel.
I don't want to bias them. They may have original ideas,
Yeah.
but I'm happy at least EHPVO, all are correct.
Yeah.
Because there is a high sag ascites, this is portal hypertension. The portal pressure is high, not HVPG. HVPG is normal. So they've understood EHPVO so well and have parenchymal extinction. So I think all are correct is my opinion, but other panelists and the chairpersons can, our president and secretary and chairpersons can also comment, please.
Yes, sir. No, I agree, sir. I mean, we have a good number of votes, sir, already. It's crossed 50. So, and all of them have got it correct, almost everybody.
Yeah, they have understood EHPVO, sir.
Yeah, not NCPF.
Can we go to the next question, Prashant?
Yeah. A patient in outpatient clinic with liver stiffness of 12 kPa and platelet count of 90,000. What is the next step? So this was very controversial even in BAVENO, that if a person is on beta blockers and has got a high liver stiffness, let's say 30, then do we need an endoscopy, or there is no added benefit of doing an endoscopy in this patient? So your take on that, because there was a lot of debate even internally in BAVENO on that.
Even in the symposium you had come on the thing on spleen stiffness. So the question I put purposely, the platelet count is 90 and stiffness is 12. It doesn't fall, this is beyond BAVENO, but you do see it. This patient may have fibrosis. Why LSM of 12? This is a typical case of NAFLD. In NAFLD, you will have a reduction in HVPG of 4 millimeter compared to an alcohol, and the liver stiffness may be under, maybe by 8 or 10 compared to a cirrhosis due to HBV. Why? So a liver stiffness of 12 is not excluding in my mind, it is the platelet. In a patient who has got a MAFLD or NAFLD or whatever, you have intrasinusoidal shunts. You have this central vein, you have the portal vein. Blood goes from portal to central. And you think sinusoids are tight walled, nothing happens. So, especially in NAFLD, there are intersinusoidal shunts, because of which LSM can be fallaciously low in some patients, and therefore, in my opinion, a platelet count is more reliable. This is a gut paper, 2021 or 22. You can look into it. So in my opinion, platelet count of less than 90, I would do an endoscopy. I may be negative, but I don't want to miss it.
So what would be the role of SSM in this kind of situation?
SSM, very reliable, very helpful in these patients.
Yeah.
But since it is not widely available, I did not put it, but splenic stiffness should be done in such a way. You are absolutely right, Dr. Duseja.
Right.
So most of them have got it right, actually.
And
Yeah.
most of them got it. And Dr. Akash asked, if a patient has a beta blocker and he has a LSM of 30, what would you do? Would you do an endoscopy? I would do an endoscopy to see the grade of varices. I would see if it is grade 2 or 3, and I would not generally accept, a low platelet count in this patient. So if LSM above 30 and low platelet, very high risk. Okay.
Agreed, sir. I think now we'll move to the last question.
Yeah. Do we have another poll question?
Yeah, we have one more.
Yeah.
I think this sir had given in a detailed way. This, I don't think people should make a mistake.
Yeah.
We can have discussion on.
Sir,
The point is, it is not the LSEC which is producing, it is not the sinusoidal cell, it is the activated hepatic stellate cell. And therefore, the activated stellate cell does not produce that much of nitric oxide. Actually, it's the endothelial cell which gives nitric oxide to the stellate cell. So NO production is not in the domain of stellate cell. It is sometimes it will produce endothelin 1, which is a major player, also produced by both of these substances. So the question was a bit tricky. It is not by the LSEC, it is by the stellate cell and contractile functions. And what neutralizes it is carbon monoxide, which will neutralize it. Okay.
So we have 3 more questions. So quickly, if we can go through.
I think we can. We can go fast.
Yeah. What level of portal hypertension threatens bleeding from esophageal varices? So I think most of them are getting it correctly, sir.
Right.
So I would like to, while you are doing it, don't be biased. About 12, the varices form and also can bleed. But what level reliably threatens is 16.
16, yes.
So this is a study by Nivens et al. So varicose, the moment you have an HVPG done and it is above 16, yaar, ye to bleed kar sakta hai. Above 12, may or may not, but above 16, very high risk of bleeding. But you are not wrong in saying above 12, because 16 is also above 12.
You should have written 12 to 15. It's okay. I think now we'll go to the next question.
Next question.
I think it's the last question.
Yeah, ये समझ में आ गया तो acute bleed समझ आ गया. So I am disappointed.
No, sir. It's only a couple of people are.
अभी और कर रहे हैं, अच्छा, ये तो और बिगड़ रहा है.
Yeah, so this is the second last question, and then we'll have one more.
So acute variceal bleed is up to 5 days. Recent bleed is 42 days. Please remember all the outcomes. An old bleed is above 42 days, 6 weeks, and recent bleed is 42 days. 24 hours, 2 days, all active bleed or acute bleed. Okay. Next, last.
We go to the last one. For primary prophylaxis.
Now it is 50-50, I think.
Yes. So, primary prophylaxis for varices, EVL is as effective, maybe a shade even better in childs A and B, but in child C, it may have its limitations. And beta blockers are good unless you have done the HVPG or pressure measurement. Beta blockers are good but may not be reliable. And also it's a lifelong therapy. Therefore, people have divided opinion. EVL can be done for primary prophylaxis as well as beta blockers. Combination of the two is better, not published enough data. And all of the above are also correct. I would say all of the above are correct, either of them, but context-wise, EVL is better sometimes in child A or B, and if patient is coming from far off. But it does not change the pressure, so the complications do not change. The beta blocker is superior to change in natural history. It's a disease-modifying agent. So combination of EVL plus beta blocker might be better, but not to confuse, first choice will remain either beta blocker or EVL. Either of them you can choose.
Right, so I think that was the last question. So thank you very much. I think we have just overshot the time.
Okay. I think, we will have, is it okay that we'll stop at this level and finish it off? Because, we have to at least finish by 1:15. Questions, maybe we'll take up in the future. No, I'll tell you how to do that. So I think it's everybody will agree that it's a wonderful talk by the doyen of portal hypertension in the world. So thank you very much, sir. You taught us from the basic to the latest, the most advanced science in portal hypertension. But we know that we are happy to listen for another 2 hours or more, because we know that the science is unparalleled, and we are all happy to listen to you. But no, there is time is a factor. We have to stop at some point of time. Thank you very much, sir. And we had 2 hepatologists, and as chairpersons and moderators, Professor Adej Duseja and Agash Shukla. They have actually interacted with the speakers and the speaker as well as the audience, and made it very interesting. And they took up the most relevant questions, which is good for day-to-day practice. And we had, and thank you so much, Professor Duseja, as well as Dr. Agash Shukla, for their valuable time and wonderful session you have created. We have nearly 900 odd registration, and there are more than 650 people listening or live even now. And there are actually 250 questions now, and we have answered some aspect of it, but I'm sure there are a lot of questions. The one option is that we can actually continue answering the questions by a later thing. We'll send the questions to the chairpersons and to the speaker, and we will answer that on at a later time. And there were actually participants from all over India, across India. There are a few from Malaysia as well as from Middle East. So thank you so much for this wonderful session. And the next ISG masterclass is on 30th July by Professor Dr. Nagesh Reddy on complications of endoscopy. And I thank all the participants for their active interest and shown, and the huge numbers took part in that. I thank the ISG Governing Council and ISG members, as well as a silent person who was doing all the work, that is Nisha. She's our IBD, she's our ISG secretary, and I'm ISG coordinator, and she's actually doing a wonderful work. And also I thank the technical team for made this a very successful, flawless, without any flaws. They have done a wonderful work. Once again, I thank the speaker, Professor Sarin, and chairpersons, and Professor Sandeep. You want to say something, and we'll finish it off.
Yeah, thank you so much, sir. You have made all expert on portal hypertension. 900 people have become expert. Thank you so much. Thanks Akash and Ajay for taking it so well. Thank you so much.
Thank you. Thank you very much.
Thank you so much.
Thank
Thank
you
you.
so much
Thank
for
you
allowing
very
me. I
much.
hope the
Thank you
pattern
so much,
was
sir.
useful.
I think, sir, we will have a session 2 on portal hypertension
Yeah,
following.
yeah, it's not complete. Still, it is half done.
Yeah. It's
Thank you
wonderful.
very much and congratulations.
Thank you,
Thank you,
sir.
sir.
Thank you. Bye bye. Bye bye. Thank you.
Bye. Thank
Bye.
you.